Hello, everyone. My name is Gabriel Miller, and I'm a summer intern here at Lyles Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Recent Developments in Personal Care. Today's presenters are Heidi Kocher and Michael Cook. Just a quick reminder, if you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address as many as possible at the end of the presentation. Gio will be sending a copy of the PowerPoint slides tomorrow as well. Without further ado, I present your speakers, Heidi Kocher and Michael Cook.
Thank you, Nathan. Good afternoon. My name is Michael Cook, and I'm a partner and co-chair of the healthcare practice at Lyles Parker in our Washington, D.C. office. In addition to having practiced healthcare law for almost 50 years, both in government and then in private practice, until recently I also served as chair of the board that oversees Virginia's Medicaid program and served on a healthcare policy committee on a volunteer basis for Pete Buttigieg and Joe Biden during the 2020 campaign, as well as several governors' campaigns. I'm also a fellow of the American Health Law Association. Heidi, do you want to introduce yourself?
Sure. I'm Heidi Kocher. I'm one of the partners at Lyles Parker. I'm based in the Dallas area. I've been practicing healthcare law for over 25 years between stints in-house at a number of large corporations and in private practice. And I focus a lot on regulatory and transactional issues for our healthcare clients.
Great, Nathan, can you go to slide 2, please? This slide is simply a disclaimer that this is for educational purposes, but it doesn't count or is a substitute for legal advice, and instead you should consult legal counsel with questions. Next slide, please. As far as the agenda, that brings us to the subject today, namely developments in personal care and other home and community-based services in Medicare Advantage and in Medicaid. We're going to provide you a very brief background on the Medicare Advantage programs, the changes that occurred in the definition of what we call supplemental benefits in 2019 and 2020, and that expanded the types of benefits that plans are entitled to cover as supplemental benefits if they choose, where personal care fits into these changes, how the plans have implemented these changes, and how your agencies might go about working with Medicare Advantage plans to provide services to this segment of the Medicare population. We'll also talk about some of the major compliance issues in personal care. Compliance is essential for agencies to have. And having been there, if you're ever investigated by the government, I can tell you that the conversations are very different depending on whether you have a compliance plan that is considered effective, and Heidi's been there as well. Next slide, please. Next slide, please. Thank you. First, let's talk briefly about what the Medicare Advantage program is. Medicare has two types of programs, what is often referred to as traditional Medicare, which is fee-for-service and generally allows beneficiaries to choose any provider that participates. Traditional or original Medicare, as it is better known, doesn't cover unskilled services such as personal care unless they're somehow tied to a skilled home health visit. Instead, personal care services have generally been covered under the Medicaid program or are paid for privately by individuals being cared for through private duty agencies. Next slide, if you could, please. However, as I'm sure all of you know, there's an optional way for Medicare beneficiaries to get their services from private insurers that contract with Medicare, namely the Medicare Advantage program or Medicare Part C, that is predominantly delivered through a managed care product. Under the Medicare Advantage program, private insurance companies contract with the Medicare program to provide services to Medicare beneficiaries and are paid a monthly premium on a per member per month basis to cover all the Medicare covered services that their members need. It's extremely popular, and now greater than 50% of the Medicare population actually is covered by Medicare Advantage programs. And the reason for its popularity is because while MA Pro plans are required to cover virtually all services that are covered under Parts A and B of the original Medicare program, and these are referred to as basic benefits, they're also permitted to provide their beneficiaries with certain additional benefits known as supplemental benefits. And in some instances, they're required to provide rebates in the form either of these additional benefits or alternatively through lowering copayments and deductibles. And traditionally, these supplemental benefits have taken the form of either things like dental or vision care that aren't covered under traditional Medicare. But they've also now been expanding to other areas as a result of changes that occurred beginning in 2019 and 2020. Next slide, if you could, please. Before 2019, the Centers for Medicare and Medicaid Services had defined supplemental benefits that plans are permitted to offer as an item or service not covered by original Medicare that are primarily health-related and for which MA plans must incur a non-zero direct medical costs. Plans have to submit to CMS as part of their bids to participate in the Medicare Advantage program for the following year, a list of those benefits that they wish to cover as supplemental benefits, and CMS makes the final decision as to whether they can include them. Up until the plan year beginning in 2021, this had occurred through a process where every year CMS announced its policies for what it was seeking from MA plans for the following year in what was called, referred to as a call letter. And that letter came out and draft around January or February. The plans and others would submit comments, and then the agency would publish a final call letter sometime in the spring. Today, more recently, that's been handled through the regulation process, basically for reasons that that we don't need to discuss today. The plans then submitted their bids and generally due today around June. CMS reviews them, and then there's a negotiation period, and the plans publish what they will cover for the following year, generally in the fall. So just as an example, for calendar year 2019, CMS would have published a draft call letter around January or February of 2018. The plans and public would provide comment. CMS would have published a final call letter in the spring of 2018. Again, now that's through the regulatory process. The plans would submit their bids around June of that year, in which, among other things, they'd set out the supplemental benefits that they wanted to cover in 2019. And there would be a negotiation period between the plans and CMS. And finally, the plans would publish what they would cover for 2019 in the fall of 2018. Time-wise, that's what occurs today as well, and it'll be important, as we'll talk about later, for if you want to cover other benefits like personal care. With limited coverage for the years beginning in 2020, which we're going to discuss in a few minutes, to be a covered supplemental benefit, the benefit has needed to be primarily health-related, and historically, CMS had considered an item or service to be primarily health-related if the item or service was to prevent or cure or diminish an illness or injury, but not if its primary purpose was daily maintenance. However, for the 2019 calendar or plan year, CMS expanded its interpretation of primarily health-related to recognize that certain types of care not previously permitted to be covered can diminish the impact of injuries or health conditions and reduce avoidable emergency and healthcare utilization. So it set up a new test for primarily health-related, namely it must diagnose, prevent, or treat an illness or injury, compensate for physical impairments, act to ameliorate the functional or psychological impact of the injuries, or, and this is important, reduce avoidable emergency and healthcare utilization, and that still remains in effect. Additionally, the benefit has to be medically appropriate and recommended by a licensed provider as part of a care plan if it's not otherwise directly provided by that provider. And these benefits cannot include items or services solely to induce enrollment. And in late 2018, CMS issued a letter further defining the, next slide, please, if you would. Sorry about that. And in late 2018, CMS issued a letter to the plans further defining the expansion of permitted supplemental benefits under this expansion, including, as you'll see there, in-home support services. Next slide, if you could, Nathan. And as you can see from this slide, in-home support services are defined as those to assist individuals with disabilities and or medical conditions in performing ADLs or IADLs within the home to compensate for physical impairments, ameliorate the functional psychological impact of injuries or health conditions, or reduce avoidable emergency and healthcare utilization. And it specifically references both personal care and as well as adult daycare services within this definition. Next slide, please, if you would. This is just a further indication by the administrator at the time of CMS, reflecting that personal care services can be covered under this change as a supplemental benefit, again, if the plans choose to do it. Next slide, if we could, please. We've included some links on some of the historical background on this for your perusal after the session has concluded. Next slide, if we could. I apologize for flying through this, but we want to get to the parts of the presentation where we can show you what's been done under these provisions, and also give you some thoughts on how you might participate in that process. This slide just discusses the fact that in 2021, CM issued a final rule for the 2022 plan year that, again, in part codifies the sub-regulatory guidance for supplemental benefits. And again, we have links there for you to review. Next slide, please. There's a second significant change in supplemental benefits that plans have been able to provide since the calendar year 2020. Based on a provision from the Bipartisan Budget Act of 2018, beginning in 2020, plans have been are now allowed to provide what are described as special supplemental benefits for the chronically ill that are not primarily health-related and may be offered non-uniformly to eligible chronically ill enrollees, under certain conditions. And the definition of chronically ill enrollees is that the individual has one or more comorbid and medically complex chronic conditions that are life-threatening or significantly limit the health or function of the enrollee, and have a high risk of hospitalization or other adverse health outcomes, and requires intensive care coordination. These are basically, among other things, addressing the social determinants of health. And the list of chronic conditions is set out in the section of the managed care manual listed on the slide. And in 2020, CMS indicated that it would be establishing a technical advisory council to determine the future conditions that should be covered. Also, in a later rule, CMS expanded it and allows plans to target additional chronic conditions if CMS approves that in advance. Next slide, if we can, Nathan. And MA plans have broad discretion in developing these benefits, and they simply must have a reasonable expectation of improving or maintaining the health or overall function of the enrollee as it relates to the chronic disease. And these are just some of the examples. Again, you'll notice that they are very broad, and they can also address the social determinants, a term that all of you, I'm sure, are aware of, that are utilized frequently these days. The plans are also required to coordinate these benefits with existing community services. Next slide, if we could. This slide provides a nice summary of what we just discussed, namely the difference between and discussion of the examples and background, both of the primarily health-related benefits, often referred to with the acronym EPHR, since as health lawyers we can't possibly not have an acronym for everything, and special supplemental benefits for the chronically ill, often referred to as SSBCI. And this was published by the consulting firm of ATI Advisory, which has just a wealth of resources in this area as well. The next slide, if we can. This slide provides a link to some of the regulatory and sub-regulatory guidance on these special supplemental benefits, and is again here for your review. And also, so where does that leave us? It's that as of January 21st, 2019, Medicare Advantage plans have had the authority, should they choose to do so, of covering things such as personal care and adult daycare as part of the supplemental benefits that they provide their subscribers. They can either charge the members an additional premium for these benefits, or alternatively can cover them using what are referred to as rebate dollars in the amount by which their bids or projected revenues are below what is referred to as a benchmark bid level. Also, I've been asked by clients whether agencies that provide these services as supplemental benefits to MA, Medicare Advantage subscribers, are required to be Medicare certified. And the answer that I've gotten from CMS is no, they are not, as long as they're licensed, properly licensed in the state to provide personal care services, or in a manner otherwise consistent with state requirements. Although the Medicare Advantage plan can require more if it desires. Also, as of January 1st, 2020, plans have been permitted to cover even a broader category of services as supplemental benefits for subscribers who meet the definition of chronically ill, again, at their discretion. Can we go to the next slide, if we could, Nathan? What we've seen is a significant explosion of the number of benefits, as Heidi's going to discuss in a minute, that plans are covering under the expanded supplemental benefits. And we've also attached links to several resources in this area, including a couple of links to ATI Advisory and the Kaiser Family Foundation, which are extremely helpful. Next slide, if we can, Nathan. This slide is from ATI Advisory again, and it shows the types of factors that plans take into account when designing benefit packages overall. Basically, they're looking at what's attractive to current and potential members, who should be eligible for these benefits, what benefits can really help members, what can help their star ratings. Star ratings are if you've dealt with Medicare Advantage programs, you know this, but they're ratings that classify the plans in their capability and competence based on on CMS criteria, and are very important to the plans because they can increase their reimbursement. What was offered last year and what are competitors offering, and what can the plan afford? Not an insignificant criteria. A critical element is a cost-benefit analysis. For example, lower emergency room admits and inpatient admits or readmits. And I know of at least one private equity-backed company that's focusing on obtaining value-based contracts that have these factors as metrics. Also, the greatly expanded and in most cases, there are a limited pool of dollars that the plans have to allocate to these benefits, especially given their need to continue to offer supplemental benefits with broad appeal, such as vision and dental care. And finally, you need to be cognizant of the fact that plans can vary their offerings of supplemental benefits from year to year, and hence the need to continually demonstrate value to the plans that decide to offer these services. Next slide, Nathan, if you would. Heidi, I believe these are yours.
Yes, thank you. As Michael said, so what we have seen with the changes in the regulatory structure and the regulatory permissions and the really recognition that these changes do provide a positive cost benefit, we have seen an explosion in EPHRB and the supplemental benefits from over the last few years. So this table simply shows the growth from 2020 to 2024 of these kinds of benefits, and you'll see that we've got things like complementary therapies was only offered by one plan in 2020, yet by 2023 it was offered by 226, and this year it was dropped to 160, so we'll see where that goes. But you'll see steady increase in growth like other things, like food and produce. So think, for example, Meals on Wheels. There were 101 plans offering those in 2020, and we've gone to nearly 1,500 plans offering those in 2024. The scope of the expanded benefits that are available can truly be breathtaking. I was, of course, always surprised to see pest control, but it actually makes a whole lot of sense. If you have somebody who is chronically ill, let's say with allergies and asthma due to dust mites or you know, roaches or something like that, it makes a huge deal. So this table is broken out into the two categories. The top again is the special supplemental benefits, and the bottom is the EPHRB. And the takeaway from, again, this slide is to see the growth over time. Again, when we started in 2020 with this table, there were just over 4,300 Medicare Advantage plans, and only 628 of those offered any of these kinds of benefits. By this year, we've got 5,700, almost 5,800 plans, and not quite half of them are offering these kinds of supplemental benefits. So this is a trend that is growing, and it is a trend that we anticipate will keep continuing. Next slide, please.
One second, Heidi, if we could.
Sure.
Under it, what you're going to also notice, for example, in in-home supports, is that you've seen an exponential rise from 2020 up through 2023, and then you see a slight decrease, although not nowhere near what we were seeing in 2020. We think the reason for that is because the Medicare Advantage regulations put in some additional requirements on the plans and changed the risk adjustment numbers and a couple of other factors that are causing plans to at least consider what supplemental benefits they will offer, and it varies across the board. We're hoping that there's a plateau and that there are some lawsuits based on these changes out there, but there is somewhat of a clawback that I don't think that hopefully will not be something that continues. Sorry.
Yeah. No, that's great. Appreciate the clarification. I forgot to mention that. Thank you, Michael. Okay, so this slide is, again, just to sort of show geographically where the plans are that are offering these kinds of benefits. Looking in on Texas, most of our counties do have plans that are offering both EPHRB and the supplemental benefits. West Texas tends to be the area where there is not as much coverage, especially on the EPHRB benefits. But we do have some SSBCI, wow, what an acronym, benefits in West Texas. So that's actually relatively heartening. Next slide, please. This slide, however, is actually a little bit more disheartening. This one shows where there are either only the EPHRB benefits or the supplemental benefits only. And as we can see, there are quite a few counties where there are only plans offering supplemental benefits. The plans that are offering both kinds of benefits tend to be clustered in the eastern half of the state. And again, West Texas is really left out there, where they have no kinds of in-home support services specifically. So again, these are available in our more metropolitan areas. They are not so much available in the more rural areas as well. So just something to be aware of. Next slide, please. So looking specifically at in-home support services, which is, again, one of the EPHRB benefits, in 2024, they're defined as support services that assist individuals with disabilities or medical conditions, as Michael said, in performing ADLs and IADLs within the home. They have to be licensed or in a way that is consistent with state requirements, as Michael said. Across the country, there are 867 plans offering these kinds of services, most of them through the EPHRB benefit, a few through SSBI, and we won't talk about VBID, that's a little bit beyond this. But I think one of the most interesting things for you all is the rightmost column, which shows which organization offer the most plans with in-home support services. And this actually lists by number which of the private insurers have plans offering these benefits. Humana and Centene obviously are the largest ones, and then we sort of drop, and Elevance and Scan, and then we drop to sort of a middle tier. And then we drop down into the 20s with some of the other plans. And again, mind you, these numbers are across the country. They are not specific to Texas. Next slide, please. These are examples of how the coverage is described in the various plan documents. These are from 2023. We unfortunately don't have any language from 2024. That hasn't been made public. But you'll see that, so for example, Elevance in its Anthem MediBlue Plus plan describes the benefit as providing companionship and assistance with independent ADLs, such as home-based chores, getting to appointments, etc. It doesn't include transportation, and it can work in conjunction with other benefits. The Molina plan in 2023 notes that members have access up to 90 hours every year. And these are in-home support services, including things such as, and they explicitly say, cleaning of the home, household chores, meal prep, or assistance with other activities. And there's, interestingly, no copay or coinsurance or deductible for those services. That's good. However, 90 days is not a whole lot of coverage. Again, would be interesting to see if Molina has more than 90 days.
90 hours, I think.
Or 90 hours, I'm sorry, 90 hours. Yeah, that's not a whole lot of hours at all. Scan actually has things, again, their description here is up to 10 4-hour in-home care visits, so 40 hours. That includes laundry, bathing, dressing, and light housekeeping, and so on. They also have 4 home-delivered meals up to 4 weeks. So essentially, if you've gotten out of the hospital, they'll give you 4 weeks of home-delivered meals. And then they have to be requested post-discharge or SNF. So again, you can see that these descriptions are widely varying kinds of services and benefits that are available depending on what the plan is. So for you as providers and agencies, it really is very important that you look at the plan documents and determine what benefits are specifically available to the particular beneficiary, because not all benefits are available to all beneficiaries. It is very, very specific and defined. Next slide, please. Go ahead.
Just one other thing on here. We'll explain where evidence of coverage fits in, but if you go to the plan's website, and then click on what they call evidence of coverage. That's how you find out whether the plan is covering something in a particular year, but we'll talk about where that fits in just a little bit. Next slide.
Thanks, Michael. Yeah. So again, this just kind of shows, again, some more tables to note where the authority and what kinds of benefits there are. Again, there's a lot of variation among the plans. And again, it just really focuses in on the need that you really need to be checking the plans. You know, what we see here is that over time, there were more plans offering these benefits, the top pie charts, and over time, the amount of hours in the 24 to 60 hour range has increased. More than 50 hours has had a big bump in 2021. That may have been a function of the pandemic, but it has decreased in 2022. And again, we don't have updated data, so it would be very interesting to see what 2023 and 2024 look like. Perhaps we'll have that data next year. Next slide, please. Okay, so again, here are some more EOC documents. Sorry, that should have been with the other one. But again, you've got, again, different descriptions, and it just, again, really is going to highlight that you need to know what the benefits are. I happen to get a chuckle out of the WellCare Dual Access one, which is that you can have an interactive companion cat or dog from a contracted provider. You know, types of pets subject to availability. Robotic companion pets are clinically shown to improve memory. You know, and so I was actually really surprised by this. I think really the robotic companion dog or cat, you know, is a very interesting benefit. I originally thought that they meant real live animals, but no, these are the robotic ones. But yeah, just again, an example of how widely ranging some of these benefits can be to the participants. Next slide, please. And this again kind of goes into the different kinds of benefits, companionship for social needs benefits. So companionship was the largest number with 130 plans, robotic pets 51. I was actually surprised that telephonic spiritual care was lower than robotic pets, but hey, I guess that is what it is. And then again, we do things, we drop into lower tiers, you know, like safety checks during meal delivery and community events and other things. So again, just to repeat, lots of different kinds of benefits out there. We are in a period of experimentation with different kinds of benefits, and we will need to see what the cost benefits are, I think, from these different benefits over time, until they really gel into a more standardized set that's across the board by the plans. In the meantime, these widely kinds of benefits actually offer an opportunity for providers as well. So again, you really need to be looking at your contracts and the plans available in your area and see what they offer and see if those are services that you can provide. What flies with one plan may not fly with another, and again, it's just all over the board. I think the term that would apply now is creative ferment is what we're in. Next slide. All right, So Michael had talked to you about some of the regulatory changes that led to all of this. We have had some further changes in 2024. Again, as a result of kind of seeing what happened, the government has decided to put some limitations on these things. So we have a state Medicaid director letter that went out in May and became effective July 9th, so 3 weeks ago, that requires, among other things, that in 6 years the states ensure that a minimum of 80% of the Medicaid payments for homemaker, home health aid, and personal care services will be spent on compensation for direct care worker wages. This is designed to ensure that we don't have as much turnover in workers. And again, the statistics are that the direct care workers who provide really valuable service are among some of the lowest paid workers in the country. So the government wants to make sure that these payments are being used to compensate those who are actually providing the care. The other thing is that the plans will need to start reporting quality measures. These were first published in July of 2022. They will start phasing in requiring the quality measures beginning in 2026, and they will be reporting them then every 6 months. 6 months after the reporting, and every 2 years, HHS will require reporting. So if you are providing these kinds of services, you are likely to soon be required by the plans to comply with and report on quality measures. If this surprises you, you should not be surprised. We have seen quality driven measures and compensation in almost every field in healthcare now. So it is actually not surprising that this is coming for these as well. And finally, this Medicaid letter indicated that states are to publish the average hourly rate paid for personal care and homemaker services and the home health aides. And again, this data is to be updated every 2 years. Earlier this year, in April, they also published a final rule for the Medicare Advantage plans, and some of the things here are that Medicare Advantage plans must notify beneficiaries in July of each year of any supplemental benefits that the plan offers, but that the beneficiary is not using, and inform the beneficiary how to access those. It probably won't be that personalized. It'll probably be a list of services or benefits that they're offering and then how to access them. But again, patients aren't often aware that they have these benefits available to them. And finally, again, looking at, the quality data, the plans have to develop and maintain bibliographies of studies or data demonstrating that a particular supplemental benefit or item or service has the reasonable expectation of improving health or chronically ill enrollees. So again, not only are you all going to be starting to probably be requested to provide quality measures, the plans themselves must justify these supplemental benefits as well. So while there is this cost benefit push, again, was the benefits previously. Now we're focusing in a little bit more on cost and quality of services. Next slide, please. As said, there is the HCBS quality measures set that was published in 2022. I'm not going to go into all of them. If anybody is interested in reading them, they are, the link is in the prior slide, and if you need any more information, please reach out to us. I am picking out here some of the select ones that I think are important that we all need to know about. So one of the quality measures are that the plans are adequate and updated at least annually. They're going to be looking at the prevention of abuse, neglect, and exploitation and unexplained deaths. And there is to be an incident management system for this. They're looking at the prohibition of restricted interventions. If anybody is familiar with the skilled nursing care and the nursing home scenario, we've already got measures in there about not using physical or chemical restraints, for example. This is somewhat along the same line. They're going to be looking for the completion of various preventive health screenings. Again, a lot of times it's easier to fix a problem when you first know about it rather than wait until it develops into a full-blown problem. So they're really wanting people to do preventive health screenings. Ensuring that beneficiary and caregivers are able to access resources for overall support overall well-being. So example here is respite and information and referrals. As we all know, in many of our families and communities, the families are serving as unpaid caregivers, and they're really doing yeoman's work on this. They're providing so much work. So this will offer respite for those caregivers. And what they're trying to achieve is a more equitable balance between spending on home care, HCBS versus institutional care. Again, everybody says that they want to age in their home, they want to stay in their home, they don't want to be institutionalized, but the way the payment systems have been set up so far has been really to just end up almost forcing people institutions. So this is looking to rebalance that spending on home care-based services versus institutional care services. And then they want to make sure that the beneficiaries are going to exercise self-determination, autonomy, and independence in their decision-making and integration into communities. That's always very, very important. How are they going to get these data? Well, the data is going to occur via looking at claims. They're going to pull EHR data. They will do beneficiary assessments, and those will be essentially done through beneficiary surveys. So a number of different ways to look at the data and, again, ensure that quality measures are being met so that we have the appropriate cost-benefit balance. Next slide, please. There are some prosecutions here. I'm only going to skip over these lightly because I know Michael wants to talk about some of these in more detail, but there have been a number of prosecutions for improper provision and billing for personal care services. A lot of these are things like agencies billing for no-shows and where aides are running personal errands, doing vacations, or socializing with family and friends. And what often happened in the first case is those wages were split between the aide and the patient, so the patient was a participant in this. Second case, US v. Tamjong, similar thing, submitted false timesheets, recorded services while he was out of the country, and on a number of occasions claimed to provide 24 hours of services in a day, probably physically impossible. The other cases are, again, fraud for submissions of claims, again, lack of services provided, max hours of care, and then paying essentially the differential, paying some of the caregivers some of that difference. So there is a lot of fraud out there, and it's something that the government is cognizant and is aware of. Next slide, please. Very briefly, again, there are regulatory actions because of the concern here for the inability to manage costs. So the OIG actually has some work plan audits announced. The first one was just announced back in June, where they're going to use EVV data to compare with the Medicaid personal care services that are billed. There was a prior audit. We're waiting for that report to be published. And there's another report on Medicaid personal care services that we are waiting for the final report on it. But the preliminary finding on those is that many of the claims were not supported by valid nursing assessments. There was no independent medical review. There was no valid physician's orders. You didn't do a criminal history check on a timely basis. Big one, of course, that's applicable on the other slide, is that the services were not documented. The aides didn't meet training requirements. There was no valid social assessment. The physician order wasn't completed and signed, and there was no plan of care. So many of these things are really documentation issues that we routinely see across the board when they do these kinds of audits. So what it really says is you need to make sure you have ticked and tied your documentation, and you need to make sure that you stay on top of that in order to justify the services. Michael, next slide, please. I think this is yours.
Yep. Well, and apologize, we're going to have to fly from here on in, given some time restraints, but this is an important one. How do you provide personal care? How do you get on the, what do you do if you want to try and get involved with Medicare Advantage? For large home health companies, for many years, they have contacts that they can speak with in the plans. However, for home and personal care companies that don't provide Medicare home health are not likely to have these contacts or familiarity with the plans. So how do you get involved? First, you need to figure out what are the MA plans that serve your area. If you're in a state with managed Medicaid care, and Texas is one of those for long-term care services and supports, you should look to the plans that you deal with under that program. Many of the plans that participate in Medicaid managed care likely are going to have Medicare Advantage plans as well. Most of these plans have a Medicaid plan, an exchange plan, and a Medicare Advantage plan. And while individuals who you're talking to for Medicaid may not know what they're providing in MA or which counties they're providing them in, they can probably get you to the people who do. Another resource for finding MA plans that service your areas is to go to the Medicare.gov website, type in the zip code, and they're going to the zip codes for your service areas, and they're going to pull up the MA plans in those areas. The plans that are required I'm sorry about this. The plans that provide supplemental benefits are going to have. You then go to their website and you look at EOC. You type in or evidence of coverage. What that's going to show you, and it's published in around September or October of every year, is what supplemental benefits are they covering in future years? And finally, you may want to get proactive and reach out to the plans in your service areas. How do you become a member of the panel, of the plan panel, so you can offer these benefits to their members? And if they don't offer services, maybe begin a dialogue for the coming year's services. Remember, the plans submit their bids for the following year in June, so these discussions generally have to be before that. And they're going to be looking for, are you a quality provider? What data do you have showing them that your service is cost effective and can help them reduce avoidable services with savings that offset the cost of your services? It may even involve initially developing a pilot program. Next slide, if you will, Gabriel. Okay, in terms of developing data, companies that have a collateral Medicaid program that cover long-term services and support may well have some data to help you out, and you may want to look on their websites. Also, you need to understand that for MA, personal care is usually delivered on an at least 8 hour a day basis in the home for long periods of time. That's not what MA plans are going to be interested in. MA plans are more than likely going to be interested in short-term benefits. Give you an example. My wife had a knee replacement. If she hadn't had me there, she'd be at home in bed for probably 4 or 5 days a week. rather than having to go to a nursing home. You may be able to show that skilled services, you may be able to show that providing, you may be able, the plans may provide for a couple of days a year of this kind of personal care benefits in the home. Also, if you've got, for chronically ill beneficiaries who tend to go in and out of the hospital frequently, the MA plan may be willing and interested in providing longer term care for those folks, but again, in personal care. But again, you're going to have to show the data to demonstrate this factor. And the plans have substantial leeway in the rates that they pay for care. So again, you better be prepared if you're negotiating with them to support requests with data, especially cost benefit, and that matters. Next slide, if we can, please. Heidi, do you want to briefly go over this slide, and then I'll
Sure.
get to specifics?
Sure. So because of the broad array of services and the fact that we're dealing with, benefits and folks being in the homes, you really are going to need a compliance plan to participate in these, with these plans. And of course, if you participate in any public programs. If you have a plan that is really only home health, you're going to need to modify your plan to address the personal care services. And again, if you don't have one, you've got to get one. Significant areas that we have seen in the past is collusion of the aides and beneficiaries. Again, that was mentioned in some of the case descriptions above. This is where the aides pay kickbacks to the clients to certify false time records and get approval for services that they either didn't provide or would never have received. Other concerns are services billed but never provided. Internal notification of when your internal quality management staff will be checking on the beneficiaries. So this is basically the aides saying, hey, my supervisor is coming this date, make sure you're in the house, not out doing shopping. Improper eligibility determinations for the patients. Something that we see a lot as well is excluded individuals in ownership. If you're doing this, you need to be checking your state and federal sanctions lists. I won't go into that in more detail. That's a subject for another webinar. The sale of counterfeit home health aid home health care aid certificates. We've seen this. There have been scandals in the past with nursing programs selling diplomas for allegedly being a registered nurse that have proven not to be true. We have the same thing in the home health aid certification space. So don't just accept a copy of a certificate. Make sure you verify it with the issuing agency. And then finally, incidences of personal theft of beneficiaries' belongings, including cash, checks, credit cards, jewelry, and other items of value. Next slide.
Yeah. Next slide, Gabriel. Okay. Aides, as Heidi mentioned, aides are paid extremely low wages, although we're starting to see an increase. But just as an example of these cases, and they're very hard to monitor. Just as an example, I was back in 2014. I was in Las Vegas about to make a presentation. At 5 o'clock in the morning, I was awakened by the DON of a personal care agency that I represented, and she told me there were 25 FBI agents walking out with their files. Needless to say, we immediately got, and this was in Washington, D.C., we immediately got criminal counsel over there, quick, fast, and in a hurry. But a bigger outgrowth of all of this was that in D.C., they found that a number of issues, for example, we found that probably the biggest issue was aides splitting again the payments with beneficiaries, and never doing the visits. It's one way for aides to be able to increase their hourly payments. Not a great way to do it, though. We also found aides colluding with others to get advance information of when the checkers were going to be there. And an example of that was we had in one of the indictments they talked about an individual who's really residing in Texas being brought back to D.C. When they found out internally that the checkers were going to be out there, and then moved that patient back to Texas. Another instance, we found that an individual was excluded in another state from participation because of fraud. She received $70 million from Medicaid using a different name. That's a set of fingerprints. And so in a very short time period, what you had was the director of the Medicaid program suspending 70% of his agencies from participating. You had he even set up his own home health care agency in order to serve beneficiaries. That's passed us somewhat, as you can, and there have been tremendous changes in the program, but nevertheless, it shows the vulnerability of these services, and then you can see, as Heidi showed, a couple of other situations that occurred: false Medicaid plans, creating fake employees. This wasn't in D.C. This is in Pennsylvania. Misusing clients' personal information and falsifying documents, and submitting claims for alleged clients who were either dead in a hospital at the time of the service or in jail. And for pure chutzpah, that bottom case, actually a woman was we had a situation of a woman who was billing for services provided by her while she was in Europe on vacation. Next slide, if we can. These are just some examples of OIG. Oh, I'm sorry. Yeah. Of OIG reports.
No, go ahead.
Yeah, of OIG reports. You can read, given the time constraints, you can read them at your leisure. We are also, if you can go to the next slide. Heidi, you want to do this real quickly?
Yeah, so as Michael has alluded to and I've alluded to, one of the major issues has been the difficulty in tracking the AIDS provision of services. So the 20th Century Cares Act actually required all state Medicaid agencies to implement electronic visit verification, as you all know. I won't go into it in a whole lot of detail, but it affects the states and the state plans. We all know that the EVV situation here in Texas is a nightmare. I'm not going to go into that in detail, but do know that, again, that this is a federal requirement that we are doing this, and there is a lot of work that is happening with EVV tracking and auditing, and that's not going to go away. Last point, I just want to make sure, again, we mentioned it earlier, but you need to be checking your federal and state exclusion lists and conducting background checks on these individuals, because again, they are in person's homes, and that is a major way that you can prevent a potential criminal from actually entering into your agency and entering into patient homes. Next slide. Michael?
Yeah, we're going to skip this slide. It's just a slide that tells you some of the issues involved in managed care contracting if you haven't been doing it before, and we can always do actually a full webinar on this if TAHCH is interested. But the key is that there are a number of issues that you've got to look into when you're contracting with managed care payers. Next slide, if you can, Gabriel. This slide just shows, as everybody knows, I think, on this, if you're involved in personal care, the principal payer historically has been Medicaid. This just shows some of the ways in which Medicaid pays for and covers personal care services. And again, you can read over this at your leisure. Gabriel, can you go to the next slide, if you will? This slide simply shows something that I think everybody's aware of, namely that in the Recovery American Rescue Plan Act, basically because of COVID, it allowed states to temporarily increase payment for direct care workers under Medicaid, and most states did this with a temporary increase in federal match to temporarily increase payments for direct care workers during the public health emergency, and it is a continuing issue because of the difficulty in getting direct care workers. It's been extended now through December of 2025. And if we can go to the next, to the end, I just want to make, to sum up, I just want to mention to you once more that there are two ways that you might be able, in Medicare or in Medicaid, to deal with some of the lower rates that are out there. The first of them is looking at entering into value-based contracts. Value-based contracts. One company I know of is trying to do this with payers in both Medicare and Medicaid by trying to increase rates based on measuring recidivism into inpatient inpatient services. Remember, at least under Medicaid, states are in fact required to pay for skilled nursing care, and also being able to demonstrate that they save money with metrics from skilled nursing facilities, and trying to show how much they save, and again, readmissions and admissions to inpatient services. I see there are two questions. We can go very, very quickly if you want to ask them, Gabriel.
One of the questions is, how can we as home care providers get a list of EPHRB plans that cover our services?
Again, I think we covered this, but basically, one, you can go to the ATI advisory website, which has a lot of useful information. Secondly, figure out which plans are offered in your service area by going to Medicare.gov, typing in the zip code, and then going to those plans website and looking at the evidence of coverage. And this is the next question, Gabriel.
The other question is, will we get a recording on this?
It'll be on the Lyles Parker website afterwards. And if you have any additional questions, feel free to call either Heidi or myself. We'll be happy to address them.
And I was just going to say also as well, if you're a TAHCH member, it's available also through the TAHCH website.
Well, that concludes today's webinar. Thank you for joining us, and thank you to our speakers, Heidi Kocher and Michael Cook. Just a quick reminder that everyone from today's webinar will receive copies of the presentation tomorrow via email. If you have any further questions about today's discussion or another healthcare law issue, please feel free to reach out to Lyles Parker or to the presenters. Have a good Wednesday. Take care, everyone.
Thank you.
Thanks. Bye-bye.
Bye-bye.